Going to directly to our last topic, panel discussion. Dr. Rajendra Rai, our showstopper, will present few cases, and I invite Dr. Tapas Maji sir, Dr. Amitabh Rai sir, Dr. Malay Bera sir, Saptarshi and Shayok to please come to the dais. And bar is open, so you can take your drinks. Rajendra, please start the. I hereby like to thank Alembic Pharmaceuticals who are actively supporting us for this academic endeavor. So thank you, Alembic, for supporting us. So Nirmalu, please come.
Good evening, everyone. After brainstorming discussion by Amitabh, this is the light bulb moment of this evening. Is a panel discussion. What we really found in the practically seeing patients, there are some confusion on treatment or investigation. One or two cases I will discuss that. So my first case is a 72-year-old gentleman presented with obstructive urinary symptom. He had a PPM 6 years ago without any other comorbidities. On examination, it was grade 3 prostate, smooth, rubbery consistency. It was 90 gram a big prostate and PSA was 1.8. So he was thought to be a benign prostatic enlargement and TRP was performed. And you can find the biopsy report. So the biopsy report suggests that it is a conventional adenocarcinoma, acina type, and the Gleason grade is 3+4, that is 7, and there is no lymphovascular or perineural invasion. 6 chips showing infiltrating acina adenocarcinoma. So my first question to Dr. Amitabh Rai, that it is a PSA that is normal, and we found that it is a intermediate risk localized prostate cancer. So do you think that if it is a normal PSA and with a conventional adenocarcinoma, biologically is different from we usually get the prostate carcinoma with a high PSA,
right,
even is a localized
correct,
intermediate grade?
Correct. So two things, I would want an IHC on this. Because regardless of what the conventional histopathology is telling us, a PSA of that level with this size of a prostate with a 3+4 is a little dicey. I would definitely ask for an IHC confirmation. If it is confirmed to be a conventional acina adenocarcinoma, then this is definitely intermediate risk.
Yes.
As for the 3+4, I'm sure the MRI etc. have all confirmed an intermediate risk prostate. So we treat it according to that. This is a biologically good type of prostate
Good
cancer.
type of
Definitely
prostate.
a very good type of prostate.
Okay, thank you. So my next question is to Dr. Saptarshi. What next in this scenario? What will you do?
So Rajendra, as far as the information that you have provided, it's appearing to be a intermediate risk disease based on the clinical T staging. It's coming around T1A or T1B.
Yeah, it is T1A because
T1A.
you find it is a 98 gram prostate and 6 chips is positive.
Only 6
so
chips are
it is
positive.
less than 5% probably.
But the Gleason is coming to be 7. So it's even a single being positive, it's an intermediate risk disease.
Intermediate risk.
So definitely I'll like to go for a staging, local staging. I'll like to go for an abdominopelvic CT scan.
CT scan, not MRI.
No, I'll like to go for a contrast. Preferentially, personally, I am not a very good reader of MR. So I'll like to go for a CT scan and also metastasis screening in these patients because I'm contemplating some form of definitive therapy.
Okay. Sir, Bera sir, do you think anything else, any other opinion of CT scan, going for CT scan or you stage with MR?
This is very much controversial. You can do CT scan or MRI, which one is easily available. But I think MR will give much more details, particularly in this case you are going to do some local treatment. For local treatment, you need to particularly neurovascular invasion or seminal vesicle invasion. So MPMRI will be little bit more helpful
Then CT.
to give the details. But regarding the lymph nodal involvement, both are same almost, because both are taking the shape of the or size of the lymph node and will give the information. But regarding the local staging, I think MRI will be little bit more helpful.
Amitabh,
I agree with sir.
MRI.
Local staging MPMRI, systemic staging CT thorax abdomen.
Yeah. So definitely MRI will. Yeah. You can say.
Just one question in this regard to Amitabh sir also. Nowadays in our setup we have the facility of PSMA PET scan. So instead of MRI, if we prescribe in this case a PSMA PET.
No, so for local staging.
I'll take that.
Yeah.
So why we said local staging, please? Why we said local staging with MRI is because any biological imaging does not have very good spatial resolution. So the reason for that is the moment you fuse the PET with the CT, the PET blurs the borders of the organ that you are actually trying to study, and that makes your local treatment decision very difficult. So if it is biopsy, like I would agree here, if you want to do, if the biopsy was not done, say for example, or you did a biopsy and got a negative report, you could probably do a PSMA guided biopsy. There it makes sense. But now you have a diagnosis. There's no point in doing a PSMA.
Yeah. So these patient actually had a pacemaker which is not compatible to MRI. So this particular
patient has limited life expectancy.
it is 72 years.
I you consider 80 years old. Why constitute different aggressive investigation management? We can put him on weight policy.
Yeah, if the age will be there is a shorter life expectancy, then definitely you can observe the patient without investigating or something when you are not trying to offering any local treatment. I think everyone will agree that.
One more situation. So I have a couple of patients with severe claustrophobia, and they refuse to undergo anything. We tried doing even a bone scan was not possible for them. So that is also another group. And I agree with sir.
Yeah.
Geriatric patients, there's no point in investigating.
Yeah.
We might as well start.
Definitely. So according to a soft thoracic CT scan actually done, and the report is the prostate is normal, and there is a resected area of TURP. There is no pelvic lymph node enlargement seen, no para-aortic lymph node or no evidence of visceral metastasis. So my question is to you, that is there anything necessary for this patient to investigate again further?
So bone scan would not be advisable for a PSA less than 20.
Yeah.
That's what the guidelines
Yeah.
says. We can avoid that. I think this probably would go for radical prostatectomy. This is also an ideal candidate if you...
Yeah, it is ideal candidate for that.
So I
but do
don't-
you think any imaging requirement of staging purpose, because we already do a CT scan, not MR.
Yeah.
So in this regard, and CT scan is
Not very
give
good.
us no much important point. So whether we are missing something or not.
So as far as radiation oncology goes, I'm happy with what we have.
Okay.
I don't need anything. From the surgical perspective, I don't know if there's anything you want to add.
Recently in this 2023 guideline, what they have mentioned is in a low risk disease, if it's a low risk disease, we don't need any particular further imaging. But as far as an intermediate risk disease is concerned, I would love to go for a metastatic screening also, preferably in a form of bone scan.
Bone scan.
Bone scan.
Yeah. What?
As sir said, by the guidelines, bone scan is not recommended, as sir said.
Because the clinical scenario is different, because PSA is already normal, but you're having CA prostate.
right,
so
right.
I think the guideline of less than 20 won't apply here, because it is already CA prostate.
If you like to do any local treatment, then you have to do it before doing local treatment, because there are many complication may happen. Then you will not be able to give it the answer.
So,
Actually, I did not express one slide. I had one slide in my presentation about a local staging guideline. This time they have mentioned that the intermediate risk disease also, you should go for a metastatic screening.
yeah, there is a debate on whether low risk disease, whether you have to do a PSA PET scan or any metastatic search. But because this is a practical scenario we are discussing here, he is anesthetist first of all. Second, we didn't do MR, so, and CT scan is not corroboratory. There is no finding of anything else. So we think here PSMA PET scan we can add here. So we did a PSMA PET scan and we found the focal and diffuse PSMA hyperexpression in enlarged prostate gland. This is the primary disease. And tracer avid subcentimeter bilateral external iliac lymph node. The SUV max on the right side is 4.56. Other lymph nodes are not PSMA expressive, so likely benign. So now, sir, Bera sir, do you have any comment here?
So these lymph nodes are very maybe suspicious, but you cannot tell it whether this is in metastasis or not. So if you do primary treatment, then you have to do good lymphadenectomy.
Yeah.
Then the biopsy will ultimately tell what is there.
Saptarsi, anything?
Is the report complete over here? Anything about
it is
bone?
complete.
There
almost.
is no bone mets.
No, there is no more. There is no bone mets or visceral mets.
So we have to rely on the PSMA PET CT report that it's a non-metastatic.
Yeah. Amitabha?
disease.
I mean, the lymph nodes are not significant by any means. So this is a local disease, not even local
disease.
regional,
Yeah. So staging is basically T1A intermediate risk, and so local treatment is requirement here. You should do a local treatment, either form of surgery or radiotherapy. What will you prefer, Amitabha? Here, after TURP.
Yeah. So I am known to refer these patients to surgery because I believe it's a single day treatment, much less toxic than radiation if it comes to, you look at long term. Although he's a 70-year-old, doesn't make a difference. But for him, it's important to get the treatment over as quickly as possible. And he will not require hormones as well. But if I take it to be intermediate risk in radiotherapy, this will definitely go for hormones, at least a short course of 6 months of hormones. So you can avoid the toxicity of hormones, you can avoid the toxicity of radiation, take him up for surgery. I would refer it to.
Yeah, so radical prostatectomy is the first option, second is the radiation if the patient choose to. So he was done radical prostatectomy with bilateral PLND because PSMA PET scan has suggests that there is low, but there is a PSMA overexpression. And on pathology, you could see it is a conventional prostate adenocarcinoma. The Gleason score is a 7, 3 plus 4. Pattern is 5 now identified, and tumor volume is 8% only. And there is no positive surgical margin, and lymph nodes are negative. So my next question is whether you need a adjuvant therapy here?
No.
Sir? No. The post-operatively follow-up PSA was 0.010 nanogram. Now I would ask to Dr. Amitabha, how will you follow up this patient? Because if the patient is already a normal PSA.
So we do serial PSA. We don't get these patients, to be very honest. Yeah. We usually get a referral when there is a PSA relapse. So as per Phoenix, point to be above the nadir, whatever nadir you are getting. So that is the point at which we come into the picture. But typically it's a 3-monthly PSA and imaging only when the PSA goes up. That's about it.
This patient, whether PSA is reliable to follow up the patient, because
after surgery now it seems that it is, because it was basically a BPH delivering PIN which became, and you caught it pretty early. So it kind of explains it. So I would probably accept the PSA.
Vera sir?
I think PSA guidance for
PSA guidance. So this is the accepted. So this is the end of it, of this case. I will discuss, if you allow, the next case. The next case is a 71-year-old gentleman who presented with a retention and catheterization was done. On digital rectal examination, there is a hard nodule on both the lobe. On USG, it was 70 gram prostate and PSA was 14. And there is no infection on urine culture. So what next? Saptarsi?
So this patient clinically has been found to be a hard nodule on both the sides with quite a high PSA of more than 10 nanograms per ml.
14.
And a 71-year-old gentleman, I'm considering there are no significant comorbidities with a good performance
there is
status.
no
So
diabetes, no
I'll
hypertension.
proceed with evaluating this patient in the form of an MPMR followed by followed by a biopsy. Maybe a fusion biopsy or a
Okay.
trust
So
biopsy
this is
depending on
very-
availability.
So this is very straightforward. So everyone, I think, yeah.
And the one question, in this case, it is a hard nodular prostate clinically. So my point of view is, can we go for a direct or trust-guided biopsy
Yeah.
without going for MPMRI in this
That
case?
is what panel will suggest. Dr. Bera, sir, will you go for a direct biopsy without doing MR in this particular patient?
I think you can do it because hard nodular prostate and PSA is high. You can, if you want to do biopsy, you can do it.
Sir, we used to do that only. We used to follow that. But again, a paradigm shift here. They have clearly again mentioned that a pre-biopsy MR is to be considered. But definitely in clinical practice, we
Basically,
often go for
even
trust-guided
after-
biopsy directly.
What is here amplified is even if you do a biopsy and get a biopsy report as a adenocarcinoma, so you have to do a local staging. So after biopsy, you have to wait for 4 to 6 weeks to get a MRI done. So it is better to have a MRI beforehand, unless you suspect this is a metastatic prostate cancer, whether PSA is 100 or 200, then you can omit MRI, go for a biopsy, search for metastasis. If you don't get metastasis, then you can do a local. So I think MRI will, before biopsy is the, in most of the patient actually, you should do it. So MRI prostate was done, on one nodule on the right side, which is Pirates 4, involving posterolateral zone. Another nodule in the left lobe involving peripheral zone, mid gland, that is Pirates 5. Seminal vesicle, VAS appears to be normal, fat planes are maintained, there is no lymph node enlargement, and bony or visceral metastases are not seen on the MRI. So what next?
The biopsy?
Biopsy. The trust-guided biopsy was done on the right lobe. 60% of the core are positive. It is a GS4+4, group gate 4. Neurovascular invasion present. Left lobe is similar, 40% of the core positivity. So, what do you think, Saptarshi?
So it's coming into a high risk.
High risk.
Group,
So it is
localized.
a conventional adenocarcinoma with a Gleason grade 4, having in the both the lobe.
Both the lobes and
So possibly is a T2C.
Minimal T2C involvement
T2C,
is there.
the
So
risk grouping is the high risk group.
again, we'll give options to this patient again in the form of local treatment.
Yeah. Do you want to do here PSMA PET scan or not?
No, after the MR has been done, I'm not considering PSMA PET scan because again, as sir rightly mentioned, that PSMA we do lack the prospective data night now. So the sole finding of a metastasis may not alter my treatment over here. So not
My question to
considering
Amito
PSMA
Boda, do you categorize the localized prostate cancers that when you want to do a PSMA PET scan and when you don't want to, even if you offer local treatment?
So I'm a part of that study, so I'm doing it routinely now. For anything, where we are planning radiation radically, we are doing PSMA for 3 reasons. One is we are getting lymph nodal positivity and we include that in radi. We don't have the luxury of, finding out whether it's positive or negative. We have to trust the PSA and we change our radiation portals accordingly. Second, there is some prognostic significance of the SUV in the prostate itself. This is emerging data, but that is something we will be using. And finally, we have a protocol of intraprostatic boost using external beam, meaning prostatic, like these 2 nodules that you have. If I took this patient up for radiation, he would be getting 40 grays in 5 fractions to the entire prostate SBRT and 45 gray to the 2 nodules. Again, trial. So the trial word keeps coming up only because we don't have the prospective gold standard data yet. But maybe in the future, this would be a patient who would definitely go for a PSMA PET.
So right now for you, it is a routine.
Yeah.
Sir, Mera sir?
PSMA?
Yeah,
PSMA you have to do.
for every patient.
you have to, before doing anything, you have to see whether staging you have to do. Without staging, how can you? But only thing is that, only I have some doubt about the MRI in all cases. MRI, whether will do or because it is costly in our situation, whether will you do before biopsy or after biopsy, that opinion may differ. Because of the cost, because of the, you can't wait. If you find that this is non-operative, you cannot do locally, then that money will be.
I think the patient is offered for a radiation, so MRI is a must. And I think for surgery also, if you put the patient for surgery, will you prefer to do MRI or not?
Before doing surgery or before doing, that I am telling you.
So at least it is agreed that if you offer a local therapy, either it is a radiation or surgery, MRI is a must. And PSMA for you is a routine, and you can customize PSMA if it is a low risk disease. But for intermediate and high risk, I think PSMA is in most of the patients. Here bone scan was done, not PSMA PET scan was done, and the PSMA suggests that there is no tracer uptake seen in any part of the body. So there is a non-metastatic tumor, and according to MRI, it is a localized prostate cancer, probably 2C. So patient is underwent radical prostatectomy and bilateral PLND. And Amitabh, do you have any opinion on this management?
No, it's fine. I mean,
It's
till
fine.
5 years back, I would have criticized this.
Yeah.
But now I am happy with this. There is data to say even in high risk, non-T3 patients, you are as good as anybody else. And then you don't need any adjuvant after this also. That's great. Provided nodes are negative, margins are negative.
Negative.
Nothing else is
But if this patient is came to you, will you prefer to do a radiation
He's
or it is a
72.
surgery? Yeah,
70.
71.
I will take him off for brachytherapy.
Brachytherapy.
Yeah, it'll be a once a week, once every 3 week, 3 fraction protocol. And for us radiation oncologists, this is one group where there is some data that we can do what you are doing, meaning we can only do brachytherapy, no hormones required.
So is there any size criteria of the prostate gland for brachytherapy? Because it is 70 gram.
Yeah,
It's a big prostate.
there used to be. There used to be. A 40 gram is too big for historical
It
data.
is 70 gram.
Yeah, so 40 gram was historically considered too big. Today, with the kind of systems that we have, it is possible to treat anything with brachytherapy. This is just a technical issue now. And if you ever have time, we can always, come down to our institute. We'll show you this new system, and this is something which has absolutely changed the way we think about brachytherapy. So it's a artificial intelligence guided system where the truss probe tells you how many needles you need to put in. This is simply mind-blowing. So I think anything we can do now, provided the patient is willing to come.
Okay. So after surgery, the biopsy report, you can see it is a conventional prostate adenocarcinoma acina type, and the Gleason grade is 4+4. It upstage. Then the truss biopsy, and there is comedonecrosis seen. The tumor occupies 60% of the entire prostate, involve both lobe of the prostate, and predominantly in the left lobe. And intraductal carcinoma prostate are seen, extraprostatic extension seen on the both side, perineural invasion, seminal vesicle invasion, all are seen, and there is a margin positivity which is 3 mm in length, and at the positive side the Gleason grade is 4+4. Prostate apex and urethral card margins are free. The right side the lymph nodes are negative, but left side there is a 6 node positive.
Standard case for adjuvant radiotherapy. There is no question. Hormones definitely, adjuvant RT also.
Do you prefer to do a PSA PET scan? Is this moment?
I'll look at the PSA first.
PSA first.
PSMA will not make me change my decision.
So post of PSA is 11.
Then definitely PSMA.
So
yes.
PSA PET scan. Do you anything? Saptarshi? This is a post. Yeah, post op. So 14 to 11. So there is little bit change in the PSA. So PSA PET scan was done, and it was seen that there is no focally PSMA expression on the local bed, but the PSA expression multiple bilateral pelvic, retroperitoneal, retrocural, mediastinal and bilateral cervical level, the disease involvement, but there is no visceral or osseous bony metastasis. So staging is probably M1A. So what next?
Hormones and radiation. My decision doesn't change. this
Okay.
patient will have a good outcome as far as disease burden is concerned, because strangely, none of the systems of disease burden classification include lymph nodes. It's very strange. They still include only bones and visceral mets.
Yeah.
So this is by
That is
definition a low burden disease which
Low.
requires both radiation and hormones.
So radiation to lymph
Radiation
nodes.
prostatic bed.
Bed.
Prostatic bed only, 55 grays in 20 fractions. That's it. And then hormone therapy is unfortunately lifelong for this patient. He's M1A.
For bed because of the margin positivity?
Yes. So the logic being, the charted data has shown us that radiating the prostatic bed, even in M1A disease, gives a survival benefit. You've already operated. If the surgery was margin negative, we would have avoided radiation.
Okay.
But since there is some residual present, and even the PSMA is, although not showing it, your margins are probably already there. So we will give it radiation to the prostatic bed, taking into consideration the charted data, and then hormones as well.
Do you quantify the margin positivity sites?
Yeah, we don't really. We actually look at the pre-operative MRI, and that's where the
Yes.
MRI becomes important. We
Yeah.
fuse it to a planning CT and basically draw that entire area and then cut it out from the rectum and bladder. So it comes out looking like, what do I call it? Hourglass kind of a shape. That is the region that you're radiating right down to the perineum. So that would be the target volume.
So here the MRI on pre-operatively suggests that is a localized disease, but you get the basically it's a advanced disease. So how often will you get that?
Well, since we don't do the surgery, we, as I said, routinely do the PSMA for all our patients. It's not very common for us to come across this. But having said that, oligoprogression is something we do get to see a lot.
Okay.
And that is that lethal Gleason score. This new term called lethal prostate cancer is Gleason's 9 and 10. That is the group where you get oligoprogression. You've done everything looks great. 3 months later, he has metastasis. That group is something where we have actually encountered this.
Okay. So thank you very much, all the panelists. We had a great session today. Oh, thank you very much.
Thank you, Rajendra, for a wonderful panel discussion. So we are concluding our this bus symposium. Before conclusion, I invite Dr. Krishna Vadan sir to come to the stage because we have some important announcement.
Hello.
Okay. You see, there is a book in my hand. This is a book on ideal conduit. Sir has written this book long before in 1990s, I think, and he has donated this to BUS to publish this. We shall made some edited version of this book and publish this. So I want to tell something.
Yeah. Regarding this CA prostate, I want to share my experience for the last 40 years of urological practice since 1983. I worked in also Thakurpur Cancer Hospital about 25 years. And in those era, there was no this PSA, no CT scan, bone scan were available. So we have to treat the patient. Patient used to even come with paraplegia. So I want to make some observation that those days only treatment was that hormone manipulation, castration. If those who have come with paraplegia, they walked out with without any crutch or anything. That worked wonderful that time. Later on, when PSA came, then your sort of diagnosis was, or picking up the cancer patients was raised. And regarding the treatment, my observation is that since then, my main practice, I have both rural and urban patients. And hormone manipulation with this 90%, they are still surviving more than 25, 30 years without all these modern, whatever the new gadgets that come. My question is, what is the aim of a surgery? It should be safe, effective, cost effective, and less morbidity, mortality, no doubt, and that can be learned easily. But most of the surgeons, the learning curve should be less, and the and the long-term sort of relief, treatment means relief. This is the aim of any surgery. But this highly robotic surgery, high-tech surgery, is it possible for our 60% or 80% our people of our Indian people? Only it is accessible to the only 10%, less than 10% people. So can we provide everybody the robotic surgery? We cannot. We have to, and so my question is, the radical surgery, can it fulfill all the, because one French surgeon last year, he commented, don't go for any PSA survey. When there is rise in PSA, surgeon will ask you, do the biopsy. When the came as a cancer, if it is a low-grade cancer, they will say, wait and watch. But you won't go to sleep, we'll go to the other surgeon, you will say, I'll do the robotic surgery, I will take out all the cancer will be removed. He will ride the train, end up with incontinence and impotency. And nobody has mentioned what is the percentage, those who are doing radical prostatectomy, what is the percentage of this incontinence and impotency? More than 60% people, every month I am seeing 3-4% they are coming with Huggies after radical prostatectomy. They are not maintained. Yeah. So, and now Dr. Rai, who has mentioned this radiotherapy, I think this radiotherapy will be the choice of treatment, either EBMRT, IMRT or brachytherapy, that will cure the patient, and also minimally invasive like HIFU or this your radiofrequency ablation may be the treatment of choice to avoid incontinence and impotency. That will be the future treatment. I don't think the radical prostatectomy will last longer in future. That is my observation and all these things.
Thank you, sir. The current treatments, they increase the overall survival rate less than our expectation. Future will say all the things. So we are concluding this session now. Already it is late. Thank you very much.